Acute inflammation is a necessary part of successful healing after musculoskeletal injury. My name is Alberto Migliore, Chief Rheumatology, Department of Medicine at St. Peter Fatebenefratelli Fratelli Hospital in Rome, Italy. We specialize in local and interarticular therapy. Many patients with osteoarthritis come to our clinic seeking pain relief and to prevent disease progression. Non-steroidal anti-inflammatory drugs or NSAIDs are routinely used to manage pain inflammation. They block pro-inflammatory pathways, thereby reducing pain. However, while often symptomatically beneficial in breaking the pain cycle and helping clinicians understand what role inflammation plays in patient symptoms, their use can have adverse effects, such as gastrointestinal bleeding and cardiovascular problems. This is especially the case with oral NSAID. When prescribing NSAID, you should always consider the risk-benefit ratio for each individual patient. There is currently much interest in the potential of moving from treatments that inhibit inflammation to those promoting inflammation resolution, a relatively new area of scientific research called resolution pharmacology. For patients who have suffered injury or are experiencing musculoskeletal pain, is there currently enough evidence to justify a shift in therapeutic approach from anti-inflammatory towards pro-resolution treatments? Several expert co-authors and I shared our opinions on this topic in a recent peer-reviewed article. The reference of this open access publication can be seen here. It has been previously suggested that the beginning programs the end, meaning that onset of inflammation is important for its resolution. Our current understanding is that inflammatory cells involved in the active phase of inflammation undergo early functional repolarization, which then initiates resolution. In simple terms, the process starts when the pro-inflammatory macrophages detect pathogens, irritants, or tissue damage and release cytokine mediators. This increases local blood flow, causes microvascular permeability, and tissue swelling. Many of the mediators that promote the inflammatory phase can simultaneously initiate active resolution. Neutrophils rapidly pass through the weakened capillary walls to engulf and degrade pathogens. These cells are followed by the slower passage of monocytes. Once neutrophils have done their cleaning job, they become apoptotic. Collectively, these changes result in the classical features of inflammation: swelling, pain, redness, and warmth. Resolution is initiated during the inflammation stage by apoptotic neutrophils releasing specialized pro-resolving mediators which inhibit further migration. Macrophages then ingest the apoptotic neutrophils, transforming themselves into resolution phase macrophages. Similarly, neutrophils switch their phenotype, resulting in reverse migration of cells back into the capillaries. The desired result is a well-healed wound and a normal functioning joint. Identification of these interrelated stages of healing and associated mediators provides clinicians and researchers with new therapeutic opportunities. Current treatments. Let us examine what treatments are available for the management of musculoskeletal pain and inflammation. As I mentioned, NSAIDs are widely recommended for the short-term treatment of acute and chronic pain, with many people self-medicating with their over-the-counter products. Their primary mode of action is the inhibition of the arachidonic acid cascade. Amongst the many available products, oral etoricoxib and diclofenac seem to be the most effective for pain and to improve function in patients with osteoarthritis. Unfortunately, some people are intolerant or reluctant to use NSAIDs, and around 2% are hypersensitive. There is some evidence that NSAID may encourage harmful pain masking, interfere with tissue healing, promote chronicity, and predispose to re-injury. I think that these concerns are valid and have had similar experience in my practice, with some patients returning with re-injury after they had quickly resumed physical activity following initial treatment with NSAID. This is despite some literature reviews concluding that these problems do not exist. What is in no doubt are the potentially serious side effects of NSAIDs, especially in oral form. We also should consider a need for long-term treatment to control the low-degree inflammation, for example, in osteoarthritis, with minimal risk of the adverse events, especially in the elderly patients population. Many healthcare professionals underestimate the importance of dose, route of administration, treatment duration, patient's age, and drug interaction. They may consequently fail to consider regarding risks and benefits. It is known, for example, that topical preparations are safer and prescribing COX-2 selective inhibitor can reduce the risk of gastrointestinal disturbances. While the debate as to whether NSAID can negatively affect soft tissue healing continues, a recent multicenter clinical study suggests that their use may be counterproductive for the long-term outcomes among low back pain sufferers. Parisien and colleagues performed transcriptome analysis in peripheral immune cells of 98 patients with acute low back pain. Resolution of pain after 3 months was associated with thousands of dynamic transcriptomal changes, but none in those with persistent pain. The researchers suggest that transient neutrophil-driven upregulation of the inflammatory response protects against the development of chronic pain. The same group examined this effect in more detail in a mouse model. Here, treatment with steroid or NSAID, but not other drugs, was associated with persistent pain despite early improvement and low neutrophil numbers. Delayed pain resolution could be prevented by the injection of neutrophils or proteins normally released by neutrophils. Finally, the researchers looked at pain trajectory in human subjects registered with the UK Biobank and identified an increased risk of pain persistence among subjects taking NSAID. Taken together, it seems that modifying the inflammatory process rather than inhibiting with anti-inflammatory drugs could be more beneficial for the treatment of musculoskeletal pain. If prolonged use of NSAID is associated with side effects and can interfere with healing, could a different approach, such as pro-resolution therapy alone or in combination, be more successful? So, what is pro-resolution therapy? Pro-resolution involves stimulating the release of specialized pro-resolving lipid mediators and activation of resolution-primed immune cells, such as M2 macrophages. This can be done in 2 ways: by giving pro-resolving mediator supplements in the form of a tablet or using drug to stimulate the endogenous production of pro-resolving mediators. Currently, many problem-solving mediators that could serve as therapeutic targets have been identified, with some already being tested in clinical trials. One challenge for researchers is to build a stable analog that is not broken down before it can act at the site of injury. Recent modification of existing compounds have produced potential valuable treatments for infantile eczema, oral gingivitis, and chronic dry eye syndrome. Whilst waiting for better analogues and fresh trial data, studies in humans involving nutritional supplements and natural medicines able to stimulate the endogenous production of problem-solving mediators are already showing promise. Though patients' numbers are generally small, I consider that current data is sufficiently mature to be of clinical value. Omega-3 fatty acids. Dietary supplementation with omega-3 fatty acids has been tested in a number of clinical studies with the aim of increasing the biosynthesis of specialized problem-solving lipid mediators. Ingesting of fish oil capsules can increase endogenous levels of these molecules and prevent pain and inflammation in diseases such as rheumatoid arthritis and diabetic neuropathy. Benefits has also been seen in coronary heart disease, Alzheimer's disease, and chronic kidney disease. Further research is needed regarding the optimum dose and treatment duration. Ginseng. The root of Panax ginseng continues to be widely used for therapeutic purposes in Asia. Ginsenosides are the main active constituents that have been shown to negatively regulate expression of pro-inflammatory cytokines and enzymes in M1 polarized macrophages and microglia. While its mechanism of action remains to be fully elucidated, several small studies suggest possible clinical benefits. Traumil. Traumil is a natural medicine consisting of 14 components, formulated some 60 years ago. Studies in mice indicate that traumil modulates signaling pathways and behavior multiple immune cell types, which promote inflammation resolution. The result is a shortening of the resolution index, meaning that traumil promotes faster inflammation resolution. Compared with an NSAID, traumil has been shown to modulate different inflammatory processes in an animal model. Randomized clinical trials and observational studies generally support the efficacy and safety of traumil for the treatment of various musculoskeletal diseases, including acute ankle sprains, tendinopathy, epicondylitis, and knee osteoarthritis. Further evidence for a possible pro-resolution effect in humans comes from Mothers et al., who found that traumil can limit exercise-induced muscle damage by modulating certain inflammation-regulating signals. Traumil appears to be at least as effective as oral NSAID in the acute setting. The consensus reached by my co-authors and I after reviewing the current landscape was that a new therapeutic algorithm could benefit the treatment of musculoskeletal pain in primary care. This is particularly relevant in patients with mild to moderate symptoms, where there is a desire to avoid or complement the effects of NSAID. It will be seen that all traditional elements are present, such as the pain ladder and the value of a clinical review at 3-7 days as dictated by the natural cycle of inflammation. So what do I do in my own practice? NSAIDs and corticosteroids are firmly fixed in therapeutic armamentarium of most clinicians. They are effective drugs, and I do prescribe them in my practice. However, their use is contraindicated across a range of comorbidities. In my experience, many patients are already aware of potential side effects of NSAID and would prefer to avoid them, especially for a long-term use. According to mass current guidelines, treatment should be decided jointly between physicians and patients. For this reason, I would encourage my fellow clinicians to provide a balanced explanation of the risk and benefit of taking NSAID, and also to inform their patients regarding alternative treatment approaches. This is what I do. Where the healthcare professional or patient is seeking a pro-resolution approach to treatment with a more focus on healing and reducing chronicity, then I usually recommend Traumil, fish oil capsules, or use of a ginseng as add-on therapy. Where long-term control or low-intensity inflammation is required, as in the case of arthritis, then I prefer in my practice to use cyclical administration of Traumil rather than NSAID, even at low doses. The existing clinical studies do not report any significant side effects of these treatments. Chief disadvantages are slower onset of pain control and the likely need to self-fund these products. Being classed as a supplement, natural or homeopathic treatment in most markets may prevent them being taken seriously by the medical and the scientific community. This is a shame, especially in the case of Traumel, for which many clinicians, the sporting community, and veterinary practices attest to its effectiveness.